Hello, this is Elena Coucher. I will be presenting the infant and family. Biological development. Maturation of all major body systems occur in conjunction with both fine and gross motor skills that allow the infant to respond and cope with the maturing of the body systems. The maturation occurs in a head-to-toe cephalocaudal and center-to-periphery proximal-distal sequence. Growth is very, very rapid in that first year. So proportional changes, these are some things that you need to know about the weight of an infant. From 0 to 6 months, infants gain approximately 2 pounds a month. From 6 to 12 months, infants gain approximately 1 pound a month. Infants' birth weights double by approximately 6 months. Birth weight triples by 1 year of age. Infants who are breastfed beyond 4 to 6 months are typically gain less weight than those who are bottle fed. So what do we want to know about height? The average birth length is anywhere between 19 and 21 inches. Length increases by 1 inch per month for the first 6 months. Length increases by half an inch a month during the next 6 to 12 months of age. This increase occurs mainly in the trunk in the early months, followed by lengthening of the legs in the second half of the first year. Growth occurs in spurts rather than a gradual pattern. Head growth. During the first 6 months, head circumference increases approximately 1.5 centimeters or 3/5 of an inch per month. During the second 6 months, the head circumference increases by 0.5 centimeters or 1/5 of an inch monthly. By 1 year of age, the head circumference increases by almost 33%. By 6 to 8 weeks of age, the posterior fontanelle closes. And by 12 to 18 months of age, the anterior fontanelle closes. So why do you think that information is important? When you're doing a physical assessment on an infant, you need to know what you would normally expect. So the nervous system, into the first year, the weight of the brain has increased about 2.5 times. Maturation of the brain is exhibited by developmental achievements. There's a table in your book that you can look at. The chest. The chest assumes a more adult contour with the lateral diameter greater than anterior-posterior diameter. At birth, the chest circumference is about 2 centimeters smaller than the head circumference. By 1 year of age, some as early as 6 months, the chest circumference equals the head circumference. The heart is large in relation to the chest size at 55%. What about the body systems and respiratory? The respiratory rate slows and is relatively stable. At birth, they're going to breathe at about 30 to 60 breaths per minute. And they're also going to be sporadic breathing. You're going to have a baby that you're going to be counting respiration zone, and they're going to be breathing. And they slow down and they speed up and they slow down and they speed up. The best way to count those breaths is to put your hand on their chest. By 1 year of age, though, these infants that do all of this periodic breathing will go down to 20 to 30 breaths per minute, and it will be more of a regular rate, regular rhythm. Respiratory movements remain, though, abdominal. Predisposing factors that relate to increased risk of more severe and acute respiratory problems. Close proximity of the trachea to the bronchi and branching structures allow for quick spread of infectious agents. They have short, straight eustachian tubes that allow for quick transmitting of any inner ear infections to spread to the respiratory tract. The immune system's inability to produce immunoglobulin A, which protects the mucosal membranes against infection. The heart rate slows. At birth, you're going to count that heart rate around 120 to 140 beats per minute, sometimes up higher depending on the activity going on with the infant, if they're upset or what have you. At 1 year, it's going to have slowed down to 100 beats per minute. Sinus arrhythmia. Rate increases with inspiration and decreases with expiration. Their systolic pressure rises during the first 2 months as a result of the increasing ability of the left ventricle to pump blood into the systemic circulation. So at birth, you're going to see a blood pressure reading of 60 over 40. By 1 year, you would expect it to be 100 over 50. Hematologic. Fetal hemoglobin is present for the first 5 months, with adult hemoglobin increasing after that time. Fetal hemoglobin, there's a shorter lifespan of the red blood cells, so increased turnover and decreased number of red blood cells. This results in physiologic anemia around the ages of 3 to 6 months. Maternal iron stores are present for the first 5 to 6 months, and then they gradually diminish. So that's why usually within that first 6 months to a year that we're going to be doing checking the H&H on them and making sure that they're not anemic. Their digestive process, amylase, the pancreatic enzyme needed for digestion of complex carbs, it is deficient until about 4 to 6 months of age. Lipase, pancreatic enzyme needed for fat absorption, does not achieve adult levels until 4 to 5 months of age. So immaturity of the digestive system is evidenced in the appearance of infant stools, which take on the consistency of the food the infant recently ate. The stomach does enlarge during infancy to accommodate a greater volume of food. With the digestive process, the newborn stomach is very small. The newborn, not the older infant. The newborn is very small. It can only hold a half to an ounce at a time. By the end of the first year, the infant is able to tolerate 3 meals a day along with an evening bottle. Newborns may have as many as 8 bowel movements a day or as few as 1 every other day or 2. By the end of the first year, the infant will typically have 2 to 3 bowel movements a day. Newborns that are breastfed could have a bowel movement with each and every time that they latch to the breast and they breastfeed. Then they get to a point where they're trying to maintain their nutrients, and they might not have a bowel movement. Maybe around 1 to 2 months old, they might not have those bowel movements like that. They'll retain it because they're utilizing the nutrients that they got. Infrequent bowel movements is considered normal as long as the stool remains soft. Due to the immaturity of the GI systems, infants may grunt or strain to stool. This is normal as long as the stool remains soft. With any gastric irritation, the infant is vulnerable to diarrhea, vomiting, and dehydration. They will dehydrate faster than anybody. The liver is the most immature of all the gastrointestinal organs throughout infancy. The immunologic, full-term infants receive immunoglobulin G, IgG, from the mother, and that's immunity against antigens the mother had been exposed to. IgA is present in large amounts in the colostrum, so it has a really good protective role against GI tract bacteria such as E. coli, viruses, rubella, polio, and enterovirus. Thermoregulation, not the last time that you will see this word. Thermoregulation is an important component for newborns and up, but in particular for newborns. We'll talk about that through newborn assessment, but you need to remember that because it will be a nursing diagnosis at some point in time when you are in the clinical setting, and not only will it be a nursing diagnosis, but you will likely see this on many more exams. By 6 months, thermoregulation becomes more efficient. They have the ability of the skin to contract in response to the cold, so that's increased. The ability of the muscles to shiver, so they have thermogenesis in response to the cold. Muscles contract equals metabolic heat. Peripheral capillaries constrict in response to cold, allowing shunting to the central organs to regulate heat loss. By 6 months, thermoregulation becomes more efficient, so heat. The peripheral capillaries dilate in response to heat, decreasing internal body temperature through evaporation, conduction, and convection. There's an increase in adipose tissue during the first 6 months to insulate the body against heat loss. Body fluid. At birth, 75% of the term body's weight is water, and there is an excess of extracellular fluid. As the percentage of the body water decreases, so does the amount of ECF, extracellular fluid, 40% at 1 year and 20% at adulthood. The excess in extracellular fluid predisposes the infant to rapid loss of total body fluid and consequently dehydration. Okay, so the renal immaturity of the renal structure also predisposes the infant to dehydration. So complete maturation of the kidney occurs in the second half of the second year of age. Now let's talk about some sensory. At 1 month, the infant fixates on an object at mid-range, a moving object to about 45 degrees. By 4 months, they have fixation of the two ocular images into one cerebral picture, binocularity. So they recognize familiar objects, especially mama. 7 months, they will pat their reflection in a mirror. At 7 to 9 months, the depth perception begins to develop. And that's not mature until 2 to 3 years of age, and so they are at increased risk of falls. Fine motor development, grasping object, ages 2 to 3 months, that's a reflex. Voluntary grasp of an object begins at 5 months. Transferring the object between hands, age 7 months. The pincer grasp, age 10 months. Removing objects from a container, around 11 months. And building a tower of 2 blocks, you would expect that to happen around 1 year of age. So here we have a table on development of fine motor skills in infancy. In 1 month, the fists mostly clenched. They have a lot of involuntary hand movements. At 3 months, they hold the hands in front of their face. That's when they start discovering their hands. At 4 months, they start batting at objects. At 5 months, they'll grasp a rattle. At 6 months, they release objects in a hand to take another. At 7 months, they transfer the object from one hand to the other. And again, at 8 months, there's a gross pincher grasp. At 9 months, they like to bang objects together. And at 10 months, there's the fine pincer grasp. They put objects into a container and take them out. By 11 months, they offer objects to others and release them. And by 12 months, they feed self with cup and spoon, make simple mark on paper, and pokes with index finger. Head control. There's lag to control. Rolling over starts at about 5 months, abdomen to back. Age 6 months, back to abdomen. Sitting by age 7 months, may still prop up on their arms. They move from prone sitting up position around the age of 10 months. I'm not going to read this. This is another chart that is available for you to read. It is in your PowerPoint this week. With the head lag. So in picture A, in 1 month, there's a complete head lag. In picture B, at 2 months, there's partial. They're getting some control of it. At 4 months, there's almost no head lag. And by 6 months, there's a well-established control. So with rolling over, at age 5 months, abdomen to back, 6 months, back to abdomen. Infants placed on the back to sleep may wake up prone. Tummy time promotes head control, turning over, crawling, and creeping. Now you need to keep hands on infant at all times when changing or weighing, because after about 6 months, they can roll off very quickly. Some good teaching that we need to give mamas and daddies. Sitting. Picture A, the back is completely rounded and the infant has no ability to sit upright at 1 month. B, the back is still rounded, but the infant can sit up momentarily with some head control at 2 months. In picture C, the back is rounded only in the lumbar area and the infant is able to sit erect with good head control at about 4 months. In picture D, the infant can sit alone, leaning on hands for the support, and that's around 7 months. And picture E, the infant sits without support at 8 months. And note the transferring of the objects that occurs at 7 months. Locomotion, movement, can't keep them still any longer. The development of locomotion. In A, the infant bears full weight on their feet by 7 months. B, the infant can maneuver from sitting to a kneeling position. In picture C, the infant can pull itself up to standing position and can stand holding on to furniture at 9 months. In picture D, while standing, the infant takes deliberate step at 10 months. Infant crawls in picture E with abdomen on the floor and pulls self forward with hands by 9 months. In picture F, the infant creeps on the hands and knees at 9 months with the belly off the floor. Psychosocial development. They're developing a sense of trust. It's a crucial element for achievement of this task is the quality of both the parent-child relationship and then the care the infant receives. A sense of mistrust to be a failure to learn. Delayed gratification leads to mistrust. If the parent always meets the need before the infant signals having the need, they never learn the ability to control their environment. If the need is delayed in being met, infants experience constant frustration and eventually mistrust others' efforts to satisfy them. Some of the social modifications they might do, grasping or biting. Psychosocial development again, in addition, when we're developing that sense of trust, the first year is divided into 2 oral social stages. Tactile stimulation is extremely important in acquiring trust. The quality of touch and interpersonal experiences are way more important than the mothering skills or the quality of the food. So at birth to 4 months, food intake is the most important social activity. Grasping, the next social modality, initially a reflex but has significant social meaning for the parents. The reciprocal response to the infant's grasping is the parent holding on or touching, which provides pleasurable tactile stimulation. Nothing sweeter than when they actually grab a hold of you and pull you into them to hug. So developing a sense of trust at 5 to 12 months is more active and aggressive modality of biting occurs. Infants can be confronted with one of their first conflicts, biting while breastfeeding. And that causes mom to become angry and withdraw the breast, yet biting brings internal relief from teething discomfort. So it's a big conflict. It can be resolved by weaning from the breast to the bottle or substituting nipples such as a pacifier and retain pleasurable breastfeeding. Of course, this is Erickson's sense of trust and the idea of the book. I have other ideas on that, taking the infant from the breast and them learning the word no. And that has worked. I mean, I did that with mine, and my daughters did that with theirs. And they learn after a while when mom takes the breast away and they say no, that they've done something bad and don't bite down again. So sensorimotor phase, the infants progress from reflex behaviors to simple repetitive acts to imitate activity. 3 crucial events occur. Separation, the infant learns to separate themselves from other objects in the environment. Object permanence, the realization that the objects that leave the visual field still exist. That develops around 9 to 10 months of age when locomotion is increasing. And then mental representation, the use of symbols allows the infant to think of an object or situation without actually experiencing it. Piaget's sensorimotor phase at birth to 24 months is divided into 6 stages. Use of reflexes at birth to 1 month. At birth, the infant's individuality and temperament are expressed through the physiological reflexes of sucking, reading, grasping, and crying. Primary circular reactions, replacement of reflexive behavior with voluntary activities such as sucking or grasping become deliberate acts that elicit certain responses. They start to relate the sound of their parent's voice with the satisfaction of being fed and will stop crying when they hear their parent instead of when the nipple is placed in their mouth. Secondary circular reactions at 4 to 8 months. The primary circular reactions are repeated and prolonged for the response that results. Like a deliberate intentions, shaking and banging a rattle to hear a noise, not solely for the pleasure of shaking, dropping and throwing a toy over and over just to watch the parent retrieve it, may fuss until it is retrieved. Imitation requires the differentiation of selected acts from several events. Infants can imitate sounds and simple gestures at 6 to 12 months. Play, they take pleasure in performing an act after they have mastered it. Many of their waking hours are absorbed in sensorimotor play. The affect, the outward manifestation, affect, outward manifestation of emotion and feeling. It begins to develop a sense of permanency, a critical component in the parent-child attachment. Coordination of secondary schemas and their application to new situations. So this is a transitional stage according to Piaget. Adds new intellectual skills to their expanding repertoire. Increasing motor skills allow for greater exploration of the environment. They climb over or move obstacles. They have object permanence, begin to discover that hiding an object does not mean that it's gone, but the removing of an obstacle will reveal the object. That's the beginning of intellectual reasoning. Associate symbols with events. Bye-bye with mom going to work. Getting plate and spoon out with time to eat. Development of body image parallels sensorimotor development. Kinesthetic and tactile experiences are the first perception of body. The mouth is the principal area of pleasurable sensation. Hands, fingers, and feet are also objects of pleasure. By the end of the first year, infants realize they are different from their parents, and they have increased interest in their image in the mirror. There are two components of cognitive development required for attachment: the ability to discriminate the mother from other individuals, and the achievement of object permanence. With attachment, the formation of attachment to the parent, there's several stages that we go through with infants. At birth, the infants respond indiscriminately to anyone. At 6 weeks, they have a social smile. When someone smiles at the infant will smile back. At 3 months, they cry, smile, vocalize more to the mother, but continues to respond to others, whether familiar or not. And at 6 months, they show distinct preference for mom. They follow her more, cry when she leaves, enjoy playing with her more, and feel most secure in her arms. At 7 months, they begin attaching to other members of the family, most often the father. At 8 months, they have the 8-month anxiety. They have fear of strangers, and it reaches a really fevered height. At 9 months, they're aware of changes in tone voice. At 12 months, most children have overcome their fear of strangers. Developmental behaviors that influence the attachment process. Differential crying, smiling, and vocalizations more at mother than anyone else. Visual motor orientation. They're looking more at the mother even if she is not close. Crying when mom leaves the room. Approaching through locomotion, crawling, creeping, or walking. Clinging, especially in the presence of a stranger. Exploring away from the mother while using her as a secure base. Now there is a disorder called reactive attachment disorder. It is a psychologic and developmental disorder. It's an antisocial personality disorder. They have maladapted or absent attachment, and it may persist into adulthood. These are probably children that are victims of physical or sexual abuse or neglect, alcoholic parents, foster care, parental abandonment or incarceration, institutionalization. Signs and symptoms are usually seen before age 5. They don't want to be cuddled. They They have failure to have eye contact, poor impulse control, and destructive to self and others, and it may lead to criminal behaviors. Separation anxiety. It's a real emotion these babies feel. And mamas feel it also when they start going through it. At 4 to 8 months, it progresses through the first stage of separation, individuation, and begins to have some awareness of self and mother as separate beings. So they start to prefer her. That starts to develop, and the infant is aware that the parent can be absent. At about 6 to 8 months, they protest when placed in their crib, and a short time later they object when mother leaves the room. At 11 to 12 months, they're able to anticipate the mother's imminent departure by watching her behaviors, and they begin to protest before she leaves. If she picks up her keys, her phone, and her purse and puts her shoes on, then they know it's coming. Stranger fear, again, around 6 to 8 months, fear of strangers and stranger anxiety become prominent. They cling to the parent, they cry, they turn away from the stranger. And if you're the nurse taking care of this infant going through this phase, complete as much of this assessment as you can while the child is in the parent's lap. The best approach for a stranger, the nurse, is to talk softly, meet the child at eye level to appear smaller, maintain a safe distance from the infant, and avoid sudden intrusive gestures such as holding the arms out and smiling broadly. At 5 to 6 weeks, the infant makes small throaty sounds. At 2 months, the infant makes single vowel sounds, ah, eh, uh. At 3 to 4 months, the infant makes consonant sounds, n, ka, ga, ba. They coo, they gurgle, and they laugh aloud. At 8 months, the infant imitates sounds. They add consonants. They'll combine the syllables da, ba, ba. At 9 to 10 months, the infant does understand no, and they can obey simple commands. At 10 to 11 months, the infant begins to ascribe meaning to the words. And at 12 months, the infant says 3 to 5 words with meaning. Socially developing, play, birth to 1 month. They enjoy tactile stimulation. They like to be held. They like to be cuddled. They like to be caressed. They like to stay warm. And they like to be swaddled. It brings them comfort. Kinetic stimulation. They like to be rocked and placed in a cradle. They like to be in strollers for walks or swings. At 2 to 3 months, for tactile, caress the infant while bathing, at diaper change, comb the hair with a soft brush, give them an infant massage. They, again, kinetic stimulation, like to use an infant swing. They like to go on car rides sometimes. Exercise body by moving extremities and swimming motion. Like to use a cradle gym. Visually stimulate them by providing bright objects. Make the room bright with pictures or mirrors. Take the infant to various rooms while doing chores. Place the infant in a seat for vertical view of the environment. Auditory stim, talk to the infant. Include them in family gatherings, exposed to various environmental noises other than those of the home, and use rattles or wind chimes. At 4 to 6 months, we want to place the infant in front of an unbreakable mirror. Give brightly colored toys to hold, small enough to grasp. We want to talk to the infant, repeat sounds that the infant makes. Da, 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 da. Laugh when the infant laughs. Call the infant by name. Crinkle different papers by the infant's ear. Place a rattle or ball in their hand. Give infants soft squeeze toys of different textures. Allow time to splash in the bathtub. They love that. Place them nude on soft furry rug and move extremities. Kinetic stimulation. Use a swing or a stroller still. Bounce the infant in the lap while holding in a standing position. Support infant in a sitting position and let them lean forward to balance self. And then place the infant on the floor to crawl. Give them some tummy time, roll over, or to sit. At 6 to 9 months, give the infant large toys with bright colors, movable parts, and noisemakers. Place unbreakable mirror where the infant can see themselves. Make funny faces to encourage imitation. Give ball of yarn or string to pull apart. Play peekaboo. Call the infant by name. Repeat simple words such as dada, mama, bye-bye. Speak clearly. Name parts of the body, people, and foods. Tell the infant what you are doing. Use no only when necessary. Give simple commands and show how to clap their hands and bang a drum. In addition, let the infant play with fabrics of various textures. Have a bowl of foods of different sizes and textures to fill. Let the infant catch running water. Encourage swimming in a large bathtub or shallow pool. Give wad of sticky tape to manipulate. They'll love that. Hold upright or bear weight and bounce. Pick up and say up. Put down and say down. Place toys out of reach. Encourage the infant to get them. And play pat a cake. At 9 to 12 months, we want to show the infant large pictures in books. Take the infant to places where there are animals, many people, different objects, shopping centers. Play ball by rolling it to the child. Demonstrate throwing it back. Demonstrate building a 2-block tower. Play peekaboo. They love that. Read the infant simple nursery rhymes. Point to body parts and name each one. Imitate sounds of animals. Give the infant finger foods of different textures. Let the infant mess with squashy food and squash food up. Let the infant feel cold, like an ice cube or warm objects, and say what the temperature of each is. If you don't do that, how can you expect them to understand that a stove is hot? Let the infant feel a breeze, like the fan blowing. Give large push-pull toys. Place furniture in a circle to encourage cruising and turn in different positions. These are appropriate toys for newborns. I am not going to read this to you, but this is testable. So this is something that you may want to study. The temperament, infants' behavioral style. It's difficult. Children may respond better to scheduled feedings and structured caregiver routines than to demand feedings and frequent changes in daily routines. They may sleep less and require more structured approaches to bedtime. Use such words as intense or less predictable rather than difficult. Highly distractible children may require additional soothing measures, such as swinging, rocking, or being carried in a pack that the parent wears across the chest or back. High activity children require vigilant watching, and parents need to take extra precautions in safeguarding the home. They benefit from increased opportunities for gross motor activity to constructively channel their energy. Slow to warm up child may demonstrate more stranger fear than other children and may require gradual and frequent preparation for new situations, such as substitute child care. Easy child can present problems in that the parents may need reminders to feed the child who sleeps for prolonged intervals and rarely cries. They may need to retrain the child because of the ease of developing habits, such as keeping the child up late or sleeping with the youngster. Separation and stranger fear. Important components of a strong, healthy parent-child attachment. It can falsely be interpreted by some as a sign of undesirable antisocial behavior. Familiarize the infant to new people. Parents are encouraged to have close friends or relatives that they visit often. Parents hold the child away from their face. They can observe while maintaining close physical contact. Best approach for a stranger, a nurse. I've said this. Talk softly. Meet the child at the eye level to appear smaller. Maintain a safe distance from the infant and avoid sudden intrusive gestures. We don't want to hold the infant down. Just complete the assessment in the parent's lap. There's no need in holding them down. Coping with concerns related to normal growth and development. In home, the babysitter in a child's home or sitter's home, they may have 1 to 6 children, and it may include the sitter's own children. So those are some alternative care arrangements. There's also centered base, which is daycare. They usually have greater than 6 children. The downside to that is they might have more sick babies that yours come in contact with. But also the center-based may include services such as sick child care and planned activity. Selection of care, daily programs, teacher qualifications, ratio of child-teacher, discipline policies, safety, meals, sanitary condition, adequate indoor and outdoor space, and the fees. Limit setting and discipline. Some disciplinary techniques are more appropriate for this age than others. Timeout is an effective approach used in disciplining a child. Place for timeout needs to be appropriate for the child's ability. A playpen is better for a child this age than a chair. It's important to stress that the earlier effective disciplinary methods are employed, the easier it is to continue these approaches. Toddlers do not understand cause and effect, so they are going to test the limits. It is who they are. They are limit testers. Thumb sucking and the use of a pacifier. What do we know about the oral? It's the place of pleasure. So that is their chief pleasure right there. They may not be satisfied completely by breastfeeding or bottle, so they've gotten everything, all their nutrients. They become very successful breastfeeders, and they empty the breast out very quickly, and they're done, but they're not done sucking. So that may be a time that mom wants to offer a pacifier. Benefits of non-nutritive sucking in preterm infants. They have shown increased weight gain, decreased length of stay, and improved pain management. There's no need to restrain non-nutritive sucking of the fingers. During infancy and early childhood, malocclusion may occur if thumb sucking persists past 4 years of age or when the permanent teeth erupt. Pacifiers, relinquished earlier than thumbs because they're less readily available. Some studies link the use of pacifiers in the early termination of breastfeeding. Others have stated no significant link. I don't know what to... I'm kind of mixed on that. I have a great friend who has breastfed all of her babies, all 6 of them. And I think it was around her 5th one, that she decided, this marathon breastfeeding I need a break. So she gave her a pacifier, and she never expected that she would have nipple confusion. She had given all of her babies pacifiers. So if you use the pacifier as a mode of satisfying the infant, then yes, it probably will be early termination of the breastfeeding. If you don't want to breastfeed because you just breastfed an hour and a half ago, and so you offer a pacifier, well, the child may be experiencing a growth spurt, or they may need to bump your milk supply up. So in not breastfeeding, you're not getting your supply built up. So thumb sucking peaks at the age of 18 months. It is most prevalent when the child is hungry or tired. Persistent thumb sucking is in a listless, apathetic child, always warrants investigation of emotional problems between parent and child, boredom, isolation, and lack of stimulation. Teething becomes a real big area of concern. 6 to 10 months, average is 8 months for the first teeth to erupt, and those are the lower central incisors. Then the upper central. Teach parents to avoid using over-the-counter medications that contain benzocaine. They interfere with the gag reflex, and they are very rapidly absorbed in the mucosa. Offer a cold teething ring. Cold is very soothing and relieving for the inflammation. Acetaminophen or ibuprofen if age appropriate. Fever, vomiting, diarrhea are not signs and symptoms of teething. This is a picture of when you can expect these teeth to erupt. I am not going to go over it bit by bit. All right. We do have a lot to talk about here on promoting optimal health during infancy and nutrition. At birth to 6 months, human milk is the most desirable. Infants, whether breastfed or not, do not require additional fluids, especially juice or water, during the first 4 months of life. Um, Water can cause hyponatremia, which can lead to seizures. We want to encourage working mothers to continue to breastfeed if that is something that is important to them. Expressed breast milk can be stored in the refrigerator safely for up to 5 days, and it can be frozen for up to 12 months. Now, I'm gonna say this: if it's going to be frozen, it needs to be frozen in a deep freeze for up to 12 months. In a regular open door refrigerator freezer, then it's good for up to 6 months. Um, we do not um, thaw or rewarm breast milk or even formula for that matter in the microwave. It kills the nutrients. Um, Plus, it warms it up unevenly, so you could cause some oral burns. Now, of course, an acceptable other form to breastfeeding is the commercial iron fortified formulas. Cow's milk is not acceptable alternative to breastfeeding or formula because it's difficult to digest. It can cause GI upset, bleeding, low zinc, iron, and vitamin C. The amount of formula per feeding and the number of feedings vary among infant. Typically, the number of feedings are 6 a day at 1 month of age and decrease to 4 to 5 a day at age 6 months. Regardless of the number of feedings, the total amount should equal approximately 32 ounces a day. But cow's milk does not need to be given until they are over 12 months. Infants being fed powder or concentrated formula can receive a substantial amount of lead from the tap water, so it does place them at risk for lead poisoning. The addition of solid foods before 4 to 6 months of age is not recommended. Start solid food introduction with iron fortified cereal, rice cereal, then introduce one food at a time. In fact, most pediatricians will recommend you not starting anything until the infant is 6 months of age. Some healthcare providers disagree on whether to give fruits before vegetables. It is believed if you give the sweet fruit before vegetables, the infant will be reluctant to take the veggies. Either way is correct, but the iron-fortified rice cereal should always be first, followed by other cereals, fruits, or veggies, and then meats. Rice cereal is preferred first due to its easier to digest and has a low allergenic property. Cereal may be mixed with breast milk, formula, or water until 6 months, and then it may be mixed with 100% fruit juice. Vitamin C does increase the absorption of iron, so since we have lost mom's iron stores that we got in utero, then that's good. Solids, commercially prepared or homemade, introduce one new food per week to test for allergies, feed small amounts, limit the amount of fat and sugar in the diet. Weaning, diluted fruit juices can be offered from a cup for its rich source of vitamin C as a substitute for milk for one feeding a day. If breastfeeding is stopped before 6 months, substitute a formula bottle for breast. White grape juice is reported to be better absorbed and safe for infants without causing GI distress. It is recommended that juice intake not exceed 4 to 6 ounces a day and not be introduced in infants less than 4 to 6 months. Solids should never be given in an infant feeder. Use a small, long-handled spoon, place on the back of the tongue, and you really want them to, as you put the spoon in the mouth, you want them to close their mouth around the spoon, and then you bring the spoon up. That's the proper way in which to teach them. So sleep and activity. Sleep patterns vary among infants. By age 3 to 4 months, nocturnal sleep lasts 9 to 11 hours. Breastfed infants awaken more often. The napping decreases to 1 to 2 per day by 12 months. Infants are naturally active. Walkers, swings, and playpens are not necessary. So dental health. Cleaning begins when primary teeth are up. Fluoride at 6 months, prevention of dental caries. We don't want to do any bottle propping. No milk in the bed, and no fruit juices. If must have a night bottle, water only. Now I don't know that any moms will actually follow that. They're going to give their baby a bottle of formula, but I'm just giving you what your book says, and I'd rather you know that for testing purposes, just in case you see something like that on HESI or State Board. So once the teeth erupt, wipe with a soft cloth and advance to a soft toothbrush as the child gets older and has more teeth. Now, this is a recommended immunizations for children from birth through 6 years of age. I've uploaded my notes so you can see what all these abbreviations are, but Hep B, hepatitis B, RV is rotavirus, diphtheria, tetanus, acellular pertussis is DTaP, HIV is Haemophilus influenza B, PCV, pneumococcal conjugate, inactivated polio is IPV, then there's influenza, MMR, mumps, measles, mumps, rubella, varicella is chickenpox, and hepatitis is Hep A. Immunizations work by allowing the body, of course, to create antibodies to fight the weakened or activated microorganisms in the vaccine. The body produces antibodies slowly and in small amounts with the first exposure, and then in larger quantities and faster with each subsequent exposure. This is why it is important to stress to parents that immunizations should be given and in the order and time frame suggested by the CDC. However, if a series is interrupted, it does not have to be started over as long as it's completed to ensure final immunity. And a lot of pediatricians, I know my pediatrician for sure, and I've seen it on some others, they have it posted on their door that if you don't want to follow the immunization schedule set out by the CDC, then they can no longer treat your child. So you will need to know any immunizations by age. You might want to study that previous screen. You have that, I believe I left it in your PowerPoint. There is no link between mercury and autism that's been proven. If the thimerosal in the vaccines cause mercury poisoning, the symptoms would affect all parts of the nervous system. Autistic children do not have the movement disorders and peripheral nerve damage that are characteristic of mercury poisoning. There is no scientific evidence or logical reason to believe that autism has a toxic cause. However, in 1999, the American Academy of Pediatrics, Public Health Service agencies, and vaccine manufacturers agreed that thimerosal, a preservative, should be reduced or eliminated in vaccines as a precautionary measure. There was a recent study from Price that supports the findings that vaccines do not cause autism. It is the nurse's responsibility, though, to report any adverse reactions after administration of a vaccine. And information statements that must be given to parents before administration of vaccines. We have to give those out, let them know what to expect, and updated information that must be given to the parent or guardian of child being vaccinated. We have to give that out. They need to know. But I will repeat, immunizations do not cause autism. So, promoting health during infancy, immunizations. Okay, so side effects and precautions. There's benefits of protection that greatly outweigh the risk. If IM or sub-Q, they're going to have slight pain and tenderness at that site. It's always best that when mom and dad give them baths at night, they just give them warm water and let them kick around in the water. We're going to have to give them Tylenol for the pain, and they're probably going to experience a slight temperature. We need to instruct the parents to call if they have a persistent high fever, continued crying, decreased responsiveness, or any seizure activity. Now, at the bottom of this slide, I'm going to let you read this if you would like to. These are some, like Hep B, it's an IM. It tells you how they're given, at what age they're given, contraindications. So you might want to read through that. This is a beautiful slide right here. Hepatitis B, it's bloodborne, of course. Long incubation period, may become chronic. Liver involved, so it can become serious. The rotavirus, isn't that beautiful? That really looks like guacamole. It's a fecal and oral infestation, fever, vomiting, severe diarrhea leading to dehydration and electrolyte imbalance, possibly death. And that stuff, once you smell rotavirus, you don't forget it. Hib, it was the main cause of bacterial meningitis in children under 5, also causes cellulitis and septicemia. Diphtheria, an acute infectious disease affecting the upper respiratory tract and occasionally the skin. The most characteristic feature of diphtheria affecting is the respiratory tract is the membranous pharyngitis with fever, enlarged interior cervical lymph nodes, and edema of the soft tissues. It gives them a bull neck appearance, may cause respiratory obstruction. The toxin also affects other parts of the body, including the heart, nervous system. It causes paralysis and cardiac failure. Tetanus, a disease caused by bacteria in a dirt-contaminated wound. It can cause severe muscle contractions. Deep puncture wounds pose the biggest risk. Think of lockjaw. Pertussis is characterized by severe coughing spells that end in whooping sound when the person breathes in. The first symptoms of whooping cough are similar to those of a common cold. Runny nose, sneezing, mild cough, low-grade fever. After about 1 to 2 weeks, the dry, irritating cough evolves into coughing spells. During a coughing spell, which can last more than a minute, the child may turn red or purple. At the end of the spell, the child may make a characteristic whooping sound when breathing in or may vomit. Between the spells, the child usually feels well. The younger the child, the more severe the symptoms. In older children, the symptoms are a little bit on the milder side. Polio, highly infectious disease caused by a virus. The virus is shed intermittently in feces for several weeks. During the time, polio can spread rapidly through the community. It invades the nervous system. It can cause total paralysis in a matter of hours. It can strike at any age, but it affects mainly children under 3. Over 50% of all cases are those. The virus enters the body through the mouth and multiplies in the intestines. Their initial symptoms are fever, fatigue, headache, vomiting, stiffness in the neck, and pain in the limbs. 1 in 200 infections leads to irreversible paralysis, and that's usually in the legs. Amongst those paralyzed, 5 to 10% die when their breathing muscles become immobilized. Varicella, lesions in various stages. They have maculas, papules, vesicles, pustules, and scabbed lesions. Or you may see all of them at the same time. It's highly contagious. Isolation is needed. You know, in the old days when you heard that somebody had the chicken pox, you went to you would go and expose your children to the chicken pox so that they would get it and get it out of the way. But it tends to be more severe in adolescents and adults than in young children. But anymore we vaccinate for it. So because over time there's been some research studies out there that it may cause more problems than initially thought. The biggest thing that we have to remember is don't give any aspirin because it could cause Rye syndrome. The measles, the first signs are a bad cough, runny nose, fever, and red watery eyes. Sometimes at this stage there's small red spots with blue-white centers that appear inside the mouth. Those are Koplik spots, and I don't think you can see them very well. After 3 to 4 days, the rash begins with red spots, first appearing behind the ears and at the forehead, spreading down the neck, arms, trunk, and finally the legs. Then they merge together on the face. Measles do not usually itch. Mumps, though, are a viral infection of the parotid salivary glands. I didn't want to have to redo my whole slide. I'm sorry, salivary glands. And it's spread by droplet. These glands typically swell. They become painful. Mumps infections are uncommon in children younger than 1 year old, but mumps may start with a fever up to 103, a headache, a loss of appetite. The well-known hallmark of mumps is swelling and pain in the parotid glands. The glands usually become increasingly swollen and painful over a period of 1 to 3 days. The pain gets worse when the child swallows, talks, chews, or drinks acidic juices. Mumps in adolescent and adult males may also result in the development of inflammation of the testicles. One testicle becomes swollen and painful about 7 to 10 days after the prodded swill. This is accompanied by high fever, headache, nausea, vomiting, and abdominal pain. We don't want this. Rubella is a viral infection. It is characterized by mild respiratory symptoms and low-grade fever. It is followed by a rash that lasts about 3 days. It may not be diagnosed due to mimicking other mild illnesses. It can cause birth defects if acquired during pregnancy. So deafness, heart defects, and mental retardation are very real possibilities for the prenatal client to experience in a newborn when she delivers. So the nurse's role in injury and prevention, we want to ensure safety in the home. We want to teach infant CPR. There's a child home safety checklist. You might want to look that over. Aspiration of foreign objects. Asphyxiation is one of the leading causes of fatal injury in children younger than 1 year of age. They pick up foreign material into the respiratory tract. It's mechanical suffocation. What do we have to do? We have to teach them hot dogs, candy, nuts, grapes. Don't give those. Baby powder. They could get aspiration pneumonia. These are some things that we have to talk about with parents, because we'll find parents that'll give their kids a full-on hot dog. Well, they're 9 months old and they're picking up stuff and they're giving them a hot dog and that child is choking. So we have to do the appropriate teaching. Mechanical suffocation. Okay, so covering of the airway is by pressure on the throat and chest. Exclusion of air, refrigerator entrapment, latex balloons, bed, cribs, cords. That's something to think about in terms of safety in the home. I knew as someone who I can't remember exactly if they had other children or if I think they did. I had some other children, but they wanted to adopt, and so they adopted this little boy and from a baby. And she was a nurse at the hospital with us, and they lost him, and he was I think he was not even a year yet. He might have been 10 or 11 months, and I'll never forget it. He was in the playroom with the other kids playing, and little, infants that are getting around and mobile, they're notorious for crawling into stuff. And so he crawled into a sleeping bag and he could not find his way out, and nobody noticed that he got into that sleeping bag, and he fought with it and he ended up suffocating and dying in that sleeping bag. So these are just some things that we need to teach parents, and we need to remember to teach parents when we're taking care of the infant in the clinical setting. Motor vehicle safety. Motor vehicle accidents is the leading cause of accidental death. It's usually due to lack of proper restraints. Car seats are in the back seat of the car. Make sure the car seat is properly installed. The proper car seat is being used for the age and size of the child, and it is in proper place in the car, never in the front seat with the airbags. And never, ever, ever leave a child alone in the car, not even for a minute. There is too much of a risk of hyperthermia and death, all these babies being left in cars. I did read a story last year that kind of really opened my eyes, though, to have an experience of or someone experiencing leaving their child in a car and them dying as a result of it. She said that it was this big old long article. She lives every day with the guilt of what happened, but she put the baby in the car, and she looked in her rearview mirror back there and saw that he was dozing off on the way to the babysitter's house. And she said she watched him as he went to sleep, and she was thinking, okay, so I'm going to get there, and I'm going to unbuckle real carefully. I'm going to pull his arm out slowly. I'm going to have the bag on my arm. I'm going to pick him up out of the car seat. I'm going to go up to the door and I'm going to knock on the door. And when she opens the door, I'm going to put my finger to my lips and shush her. And then I'm just going to go lay him down in his bed there at the babysitter's house. And she said she thought about this scenario over and over again because she wanted to make sure that he got his rest out completely. And she thought about it and thought about it and thought about it till she thought she had done it. And she went to work, which was past her babysitter's house. And she got in the car and went to go pick up her child from the babysitter's, went to the door, and she said, was really shocked to see this woman. And she said, "You never brought him this morning." And so that's when she realized that he was still in the car seat. So, I mean, there's probably some circumstances out there that maybe we need to teach how to not be distracted, to be distracted parents and distracted drivers. Do something that keeps you seeing your child and lets you know that, hey, they are still in the car. Trauma is the leading cause of accidental death in children, and falls leading to the cause of traumatic injury in children. Best advice, never place a child of any age unattended on a raised surface that is not designed to protect the child from accidental falls. I would say also that as a healthcare provider, when you are taking care of a child in a hospital setting, you need to ensure that you raise those rails and keep them up when the child is in there. Second highest incident of injury, poisoning, occurs in 1-year-old child. The major reason for ingestion of poisons is improper storage, plants, button-sized batteries, and inhalation. All poisons should be locked in cabinets. High is not good enough because they like to climb. Let me just tell you, my poor daughter has had to call poison control twice with my grandson. Because the first time, he was out in the garage with them and they were piddling around doing some stuff, and he found a can of, and she was pregnant with the second one, he found a can of spray paint and sprayed it in his mouth. And so here she is, 32 weeks pregnant, taking this big old boy running up to the house, trying to get all the paint out, having to call poison control. And then after Charlotte got here, she was probably 6 months old. She was running a fever, and Amanda had called me and said, how much Tylenol can I give? So I'm giving her the dosage of Tylenol. And then I hear, What? Show me. I gotta go. So she calls me back to let me know that she had to call poison control again because she put the Tylenol bottle on the cabinet, pushed it back, but she didn't put the lid on it, and my grandson got a hold of it and drank some Tylenol. I don't know how much Tylenol he drank, but he came in there telling her nummy. That was nummy. So you never know. Push things back is not good enough. Make sure you put the child protective lid on there is good enough. And put it up high and lock it in cabinets at the same time. And I also read a story of someone whose son got a hold of one of those button-sized batteries, and he did not know what was wrong with him. He thought he was coming down with an illness. The wife was out. One thing led to another. Went to the hospital. They couldn't find anything wrong with him, and they finally did an EGD, and when they went down, they found the battery, and it had, in just a few hours' time, had already started eroding through the esophagus, and he's on a permanent trach. Burns can happen when the hot water heater is too high. 120 degrees or lower is best. Excessive sunburn, house fires, electrical fires, sockets, heating elements such as radiators and floor furnaces. On stoves, we want to turn the handles back and take the front knobs off. Drowning can occur in just an inch or two of water. Never leave infants alone around water even for a minute. Bodily damage, sharp objects, excessive noise, constriction injuries like tight clothes, homicide, and animal attacks are some other things that can, traumas that can occur for the infant. We have to do injury prevention, ensure safety in the home, and teach infants CPR. Colic, that's it's like a intermittent abdominal pain that these infants, they go through it. It's terrible. If you've never had a colicky baby, you don't have any idea what I'm talking about, but if you've had one, man, I feel for you. It's the worst thing that you have to go through in life. There's patient teaching for managing a colicky infant on page 907. 15 to 40% of all infants experience it. A healthy 6-week infant will cry for about 3 hours every day as a hallmark sign. Crying and fussing are more prevalent in the evenings. They'll hit that 7 o'clock mark and wah, they're going. By 12 weeks of age, their total amount of crying is reduced to about 1 hour a day, and the infant becomes better and able to soothe themselves. Colic is inconsolable crying that lasts 3 hours or longer per day, which there is not a physical cause. It does usually resolve, though, by 3 months of age. It can last a little bit longer. Failure to thrive is growth failure. I want you to look at box 31.3 on page 909 at the prognosis and care management. I saw something the other day about a woman sharing her baby's picture on Facebook, and she just did not know that she was starving her infant. Now, I think sometimes we push these mamas to breastfeed, and maybe they're not breastfeeding the right way, or for some reason they have reduced milk. I don't know all of the reasons, but we sometimes push them so much to do the breastfeeding, and they feel so much pressure they might feel pressure from their mom, they might feel pressure from their aunts or their sisters to breastfeed because they all did. And so consequently, this baby at a month old was, oh my gosh, the picture of him was horrible. I was like horrified when I saw it. She just didn't know that she was starving him. She didn't know he was starving at all. So, it's a very real thing that we have to deal with in healthcare and nursing. And we also have to look individually at the caregiver. We can't automatically jump into assume that they're not good parents. Sounded like a perfectly good parent. She just did not know. She was uneducated. All right, so SIDS, sudden infant death syndrome. Risk factors: maternal smoking, co-sleeping, allowing an infant to sleep with the adult, sleeping prone, soft bedding, quilts, pillows, crib bumpers, etc. I read a story when we started going to couplet care at Baptist Little Rock, and that's where we take care of mom and the baby together in the room. And I was doing some research on it. There was a couplet care that was initiated in another state. This mom had a C-section and was just having extreme difficulty staying awake, but she was trying to breastfeed her infant. And so the nurse had come in once again. The baby was crying. She was asleep. And she asked her if she wanted to supplement, and the mom said no, she wanted to breastfeed. The woman had very, very large breasts. So they started, she initiated the breastfeeding. The nurse got the baby to latch on. Baby was latching and nursing, and she left the room. And when they came back in sometime later, they found that mom had fallen asleep, and her breast had fallen over the infant's face, and she had suffocated the infant with her breast. So, I'm not against co-sleeping, but I think we have to look at it as a case-by-case basis. And if you have somebody that you know is definitely a hard sleeper, probably co-sleeping would not be an excellent idea. Larger adults may not co-sleep with infants very well. They may not be aware that they've rolled over on that infant. Protective factors: breastfeeding at least the first 16 weeks, use of a pacifier, and sleeping supine, back to sleep. That's really big initiative out there right now, is back to sleep. The care of the family following such a tragedy, we have to support them, and we can't blame them. I mean, you certainly can't do that, especially think about the poor woman that just delivered her baby, and I think I would have probably wanted to go and cut my breast off afterwards. Okay, positional plagioccephaly, that back to sleep thing going on since 1992, they need to be front to play because this is what can happen. These wonderful pictures here. They get a misshaped head. It's caused by the infant on the back most of the time because they have soft head bones and cranial molding happens. They need 30 to 60 minutes of tummy time a day. If not, they're going to end up with a helmet that's going to be worn 23 hours a day. So it's very important that we teach. Back to sleep is great, but you also have to give them tummy time. Apparent life-threatening events, aborted or near-miss SIDS. There's diagnostic evaluations for that. Therapeutic management would be that we're going to send these babies home on theophylline or caffeine to keep their heart rate up. They're going to have some home apnea monitors that go off so we know if they stop breathing, and it alerts us. Family support and CPR training. I think all new parents need CPR training. That is the end of the infant and family. I will see you in the classroom.